Good afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on changes to serological testing of Lyme disease. My name is Catherine Paphitis. I'm the enteric zoonotic specialist at Public Health Ontario, and I have the pleasure of moderating today's session. Before we begin, I would like to do a land acknowledgement. We are fortunate to have people attending from across Ontario, but this PHO Rounds is hosted virtually from Toronto, and we acknowledge that the land we are hosting this virtual educational session on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. I will now mention a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have any questions during the session, and a discussion and question period will follow the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. I would finally like to state that as the moderator of this session, I have no conflict of interest to declare. It is now my pleasure to introduce my colleagues and the speakers for today's presentation, Dr. Samir Patel and Dr. Richard Mather. Dr. Samir Patel is a clinical microbiologist at Public Health Ontario and an assistant professor in laboratory medicine and pathobiology at the University of Toronto. He has an MSc and a PhD in tropical medicine/infectious disease, both from the University of Toronto. He also completed his fellowship in clinical microbiology at the University of Toronto. Dr. Patel provides scientific clinical oversight for vector-borne disease testing. He oversees Lyme disease testing in Ontario and has extensive experience in diagnostic microbiology, including the processing and storage of clinical specimens. Dr. Richard Mather is a public health physician with the enteric zoonotic and vector-borne disease team at Public Health Ontario. He is an assistant professor at Queen's University in the Department of Family Medicine and has an MSc in the control of infectious diseases from the London School of Hygiene and Tropical Medicine. I will now hand it over to Richard to begin today's presentation.
Thank you, Catherine. I'm happy to be able to talk today about changes to serological testing of Lyme disease. The learning objectives for today's session are that participants are able to describe the epidemiology of Lyme disease in Ontario, identify the new Lyme disease testing method and how it compares to previous testing methods, and interpret lab results using the new modified two-tiered testing for detection of Lyme disease. I'm going to start by giving a brief introduction to Lyme disease, and I will describe the epidemiology and clinical stages of Lyme disease. I'll then hand things over to Samir, who will be discussing diagnostic testing and changes to the serological testing. And I will then go over implications for practice and review some case studies. Lyme disease is the most common tick-borne infection in Canada. It's a vector-borne disease caused by infection with the bacteria Borrelia burgdorferi. And the bacteria is transmitted to humans in Ontario through the bite of an infected black-legged tick, known as Ixodes scapularis, that has been attached to the host for more than 24 hours. Black-legged ticks typically have a 2-year life cycle, as shown in the image on the left. In the first year, eggs are laid in the spring and hatch into larvae. The larvae can acquire Borrelia burgdorferi by feeding on small animals, such as the white-footed mouse. In the second year, the larvae typically develop into nymphs in the spring, and infectious nymphs can feed on animals, including humans, in late spring and summer before developing into adults in the fall. The image on the right shows the relative size of ticks at different stages, with the diagram included to show the scale. As you can see, the left is the adult female, followed by an adult male, and a nymph and a larvae. So the nymphs are quite a bit smaller than the adult ticks. The nymphal ticks are most likely to transmit Borrelia burgdorferi for 2 main reasons. The first one is they're active in late spring and summer, which is when humans are most often in areas where ticks live. And they are small in size, so harder to detect when attached to a person. And the images on the slide, the one on the left shows 5 adult female black-legged ticks in different stages of feeding. The smallest one is the unfed tick, and the largest one is one that is fully engorged. The image on the right shows 3 nymphal ticks in different stages of feeding. So as you can see, the fully engorged nymphal tick is much smaller than the fully engorged adult tick, which is why when a nymphal tick is attached to a human, it is harder to detect. These 2 maps show the estimated risk areas for Lyme disease in Ontario. PHO produces these maps annually. The map on the left is from 2016. The map on the right is from 2022. The estimated risk areas are shown in yellow and are locations where black-legged ticks have been identified or are known to occur, and where people have the potential to come into contact with infected ticks. The estimated risk maps are based on active surveillance or tick dragging, which involves going out into the environment to look for ticks. And a risk area is a location where at least one Ixodes scapuloris tick is collected during both spring and fall sampling events. If you can compare the map on the left from 2016 to the one from 2022, you can see that the estimated risk areas are expanding. Ticks can be found in most parts of Ontario and cluster along the north shores of Lake Erie, Lake Ontario, and the St. Lawrence River, but it is possible to find ticks anywhere in Ontario where they may have been transported by migratory birds. Although ticks are primarily active in spring, summer, and fall, they can be found any time of the year when temperatures above freezing and the ground isn't covered by snow. The ticks thrive in wooded, brushy areas with undergrowth and significant leaf litter that keeps the ground damp. The number of reported cases of Lyme disease in Ontario has been increasing in recent years. This graph shows the number of probable and confirmed cases of Lyme disease over the last 10 years. The bars represent case counts and the line shows the rates. There's been an upward trend in cases across the last 10 years with a sharper increase starting in 2017. The total number of reported cases has increased almost tenfold from 175 cases in 2012 to just over 1,700 cases in 2021. Lyme disease presents with varying symptoms and has three phases that can overlap. Early localized Lyme disease occurs 3 to 30 days after an infected tick bite. Early disseminated disease can occur 1 to 3 months after a tick bite, and late disseminated disease occurs more than 3 months after a bite. In early localized Lyme disease, which usually occurs 7 to 14 days after the bite from an infected tick, it is characterized by the erythema migrans rash, which is an expanding rash greater than 5 centimeters, which occurs in about 70 to 80% of infected patients. The image on the slide shows the classic bullseye rash that is characteristic of erythema migrans, but it's important to note that the rash can have varying appearances. The reference on the slide, the Canada.ca Lyme disease page, has images of a number of different appearances of erythema migrans rashes and images on different skin tones. So it's important to note that you don't need to have this classic bullseye appearance to have an erythema migrans rash. Patients may also present with acute signs and symptoms that are similar to other viral illnesses, including fever, generalized arthralgias and myalgias, headache, and lymphadenopathy. If untreated, the bacteria can disseminate through the bloodstream and affect other parts of the body. Patients with early disseminated disease can present with generalized fatigue or weakness. They may have multiple erythema migrans lesions, and they can have neurological manifestations such as facial palsy or meningitis, as well as cardiac symptoms such as heart block. If Lyme disease remains untreated or is diagnosed later, it can persist for months or years. Patients with a late infection may commonly present with arthritis and present with neurological and cognitive manifestations. I'll now hand things over to Samir, who will be discussing Lyme disease serological testing.
Thanks, Richard, and good afternoon, everyone. I'm going to talk about the changes in the Lyme disease serology testing that has been implemented since April 1st of this year. I want to go through some of the data, the rationale behind it, as well as what does it mean in terms of the interpretation of the new Lyme disease testing methodology. So as you all know, Ontario, as well as other jurisdictions across Canada, as well as parts of the US, have been using two-tier testing, which is an ELISA testing followed by the Western blot. And this has been the mainstay of serological testing for diagnosis or supporting diagnosis of Lyme disease for many, many years, since late 1990s and up until now as well. We know that the sensitivity of two-tier testing varies significantly depending on what stage of Lyme disease patient are being tested. So as you can see on the right-hand side, if you're testing someone at the early localized stage, where patient is within the 30 days of the tick bite and presentation of erythema migraine and acute phase, the sensitivity is not very good. And we've known that for a very long time. The sensitivity can be as low as 25% to 40%. And really, the classic dogma has been that you treat and you diagnose a patient during this stage as a clinical diagnosis, and should not testing should not be used to make a diagnosis. As Richard mentioned, there are several stages. If not diagnosed and treated early, patient can go into the early disseminated and late disseminated disease as well. And again, the sensitivity goes up as the stages goes up from the early disseminated to late disseminated disease as well. And there have been many studies that have shown that the antibodies during the late disseminated disease are readily picked up using the serological testing that have been used for many years in Ontario and elsewhere as well. However, the challenge is still with the early localized disease. So there have been lots of research over the last 15, 20 years looking at different ways of identifying and diagnosing Lyme disease through laboratory testing. And people have looked at it from many different aspects, metabolomics, genomics, and other testing methods to see, is there a better test that we can use to improve sensitivity? So for the last 10, 12 years, there have been a lot of studies looking at modified two-tier testing. And in this algorithm, a blood sample is tested using the ELISA method. And if it's negative, then the report would go out and suggest that there is no serological evidence of infection. However, if a sample is positive or indeterminate, instead of using the Western blot that was relied on in the standard two-tier testing, the approach is to use a second ELISA method to identify whether or not the patient has antibodies against the Lyme bacteria as well. And at the end, you would provide an overall results. So what is the difference? Instead of using a Western blot as a second test, we would be using an ELISA method as a second test to provide an overall interpretation of antibodies that would be detected against Lyme bacteria. And there have been quite a few studies over the last 10, 12 years looking at what is the sensitivity, what is the specificity. And this was a study that I wanted to highlight. I can't highlight all of the studies, but I chose several studies to sort of highlight what the sensitivity and specificity of this new algorithm is. This was a study that was published by the Center for Disease Control several years ago, and they had compared the sensitivity and specificity of modified two-tier testing versus the standard two-tier testing. So in the modified, in the left-hand side, there were a couple of different ELISA methods that were used, and if they were positive, then they would use another ELISA method to determine overall interpretation. In the standard, as we've always known for many, many years, that they would use the ELISA method. If it's positive or indeterminate, then they would go on to do the Western blot testing to determine the antibodies. And what the results were, and if I could just point you to the green arrows, and on the left side, there are different stages. And as I mentioned earlier, depending on what stages that you test the patient on, there is a difference in the sensitivity as well, because the level of antibodies would be different along different stage of antibodies. So if you do modified algorithm, so that's a Western whole cell lysate followed by the VLSC, which is a specific peptide ELISA method, you could see and compare it to the standard algorithm, which is the ELISA followed by the Western blot or immunoblot, you see a higher sensitivity. 58% in the early localized disease versus 43%. If you look at the acute phase, 76% versus a 61%. And as you go down in terms of the stages of disease, both the modified two-tier testing and the standard two-tier testing, the sensitivity goes up significantly and reaches almost close to 100% or so, particularly in the late disseminated disease as well. So that's the sensitivity. In terms of specificity, it was quite comparable when they looked at the control samples from people with the different conditions, whether it's infectious causes or non-infectious causes such as rheumatoid arthritis, multiple sclerosis, and other conditions as well. The specificity was quite comparable between the modified two-tier testing versus the standard two-tier testing. This was another study that was published out of Nova Scotia, and where they looked at the performance of a modified two-tier testing and compared it with the standard two-tier testing. The study took place between 2011 and 2014, over 10,000 patients that were tested using the standard two-tier testing, which means ELISA followed by the Western blot. But in addition, samples that were positive for the ELISA, they were also tested by second ELISA method. So in this case, it was whole cell lysate followed by the C6 peptide ELISA as well. And what they found was that 271 patients with both whole cell lysate and C6 positive, they performed the chart reviews to determine whether or not it was a true positive or not. Unfortunately, or one of the limitations was that patient charts with whole cell lysate negative, which was the first test, was not reviewed. So we can't really look at the sensitivity on this. But what we can tell is that modified two-tier tested detected 25% more early localized cases compared to the standard two-tier testing. When they looked at the specificity, they found that the specificity was quite comparable. In terms of looking at and modeling different stages of disease, and again, these are the different references that they use to model the disease. And what they found was, again, the sensitivity of modified two-tier testing is slightly higher. It's nothing to brag about. It's not anywhere near 90%, 95% that we would ideally want, but it is better than the standard two-tier testing that we had been currently using. In the early disseminated, late disseminated, the sensitivity becomes is very good and reaches close to 100%. The specificity is also important as well, because we don't want to provide false positive results to any patient that may not have Lyme disease. And as you can see, that the specificity is quite high, over 99%, when they model the cases and the samples and the results that were used in different studies. So again, these are some other publications that were using a different clinical manifestation. Some use erythema migraine, early neuroborreliosis. Some papers only looked at the acute erythema migraines. Some studies looked at disseminated disease, Lyme arthritis, and others as well. If you compare that to the standard two-tier testing to modified two-tier testing, again, the modified two-tier testing is a two ELISA method. You can look at the numbers and see that consistently, particularly in the early localized disease, the modified two-tier test provides a higher sensitivity than your standard two-tier testing as well. When you look at the Lyme neuroborreliosis or Lyme arthritis, both of these tests are quite comparable and reaches close to 100% or 100% in many of the studies as well. When you look at the specificity, again, healthy and symptomatic controls, healthy controls with other disease, and two ELISA method. Doesn't matter what ELISA assays were used, whether it's a whole cell followed by C6 or VLSC followed by C6 or whole cell followed by C6 or VLSC, the sensitivity is quite good. So we know that the false positive rates would be significantly lower because we're achieving specificity over 99.5% or higher in many of these algorithms as well. So as I said, there are lots of studies. People have been looking at it for last 10, 12 years. And this was a quote that I wanted to sort of talk about from the New York Times. And really, science rarely advanced by revolution. Science is an activity carried out by hundreds of thousands of researchers, all contributing to general picture that eventually emerges. And what I mean by that is that there are lots of studies now have showing and adding an evidence that we're comfortable that modified two-tier testing is better than the standard two-tier testing that we have been using, particularly in the detecting higher cases in the early localized disease. There are advantages and disadvantages of using modified two-tier testing compared to the standard two-tier testing. So some of the advantages is that, based on the studies that I've shown, I hope I convince you that there is an improved sensitivity in the detection of early localized disease. It's less costly, less laborious, and less subjectivity. Again, Western blot, it is subject to interpretation because it is a manual reading to see if a band is present or absent or faint or not. And it does provide a faster turnaround time compared to your standard two-tier testing. The disadvantages, again, modified two-tier testing will not replace your clinical judgment and clinical diagnosis, particularly in the early localized disease, because sensitivity is less than 90%. And many of the studies have shown that it's about 60%, 55, 60%, which is not good enough to solely use laboratory results to make a diagnosis. And similar to standard two-tier testing, we can't differentiate between recent infection and the past infection or reinfection. Because again, we're looking at antibody response. We're detecting antibodies. And we know that the antibodies persist for months, if not years. So it's very difficult to differentiate whether or not a patient that is in front of you is a new infection or past infection based on just the antibody response as well. And it may provide, although the data is unclear, lower specificity in low prevalence area. But as Richard mentioned, in Ontario, we are seeing increased cases, and also based on the tick surveillance, we are seeing increased activities in many parts of province as well. So what are the other international national bodies have said about the modified two-tier testing? So these are just some of the quotes that I picked out from the CDC and Canadian Public Health Laboratory Network. And CDC had said, when cleared by FDA for this purpose, serologic assays that utilize EIA rather than Western blot assays in two-test format are acceptable alternatives for lab diagnosis of Lyme disease. Similarly, this was a group that I have been involved in, Canadian Public Health Laboratory, and we reviewed our own literature and came up with a similar conclusion as well, that two-tier testing, modified two-tier testing is an acceptable alternative to standard two-tier testing. IDSA statement that was published 2 years ago similarly made such a comment that serum antibodies tests should be performed using clinically validated assay in which an enzyme immunoassay or IFA is followed by IgM and IgG immunoblots, or in a modified two-tier testing protocol in which 2 EIAs are performed sequentially or currently without use of immunoblots. So as of April 1st, PHO has implemented a modified two-tier assay in which patient samples or blood samples will be tested using ELISA method. In this case, we're using whole cell lysate. If it's negative, no further testing will be done. If it's positive indeterminate, we would then perform a second ELISA method, which is an VLSC Pepsi-10 recombinant ELISA method. And we would provide an overall results to the submitter. In terms of the testing indications, it hasn't changed significantly. So compared to the standard two-tier assay, modified two-tier assay indication is that patients should not be tested if they're asymptomatic or following a tick bite. Again, serological testing for individuals with erythromigraine is generally not recommended because it is a clinical diagnosis. serological testing is useful to support clinical suspicion of Lyme disease. And this is where it's very important to have both the acute as well as the convalescent sample for the laboratory-based confirmation of Lyme disease. We still don't have a good assay, and certainly the serological testing should not be used to assess treatment response because the antibodies do not go down and they persist for many, many years. If a European Lyme is suspected, please let the laboratory know that the patient had traveled to Europe and there is European Lyme is being suspected in the patient as well. Because our modified two-tier assay will not pick up, so we would have to test the sample and then send it off to National Microbiology Lab for confirmation for European specific Lyme disease. These are the interpretation. I won't go through all of them. They can be found on our test information sheet at Public Health Ontario, but these are some of the algorithm as well as the interpretation that would be provided on individual test results as well. And I'll pass it back to Richard.
Thanks, Samir. So now I'll be talking about some of the implications for practice of these testing changes. As the modified two-tier testing is more sensitive than the standard two-tier testing for detection of early infection, there is the potential for more early cases to be identified. However, it's important to remember that diagnosis of early localized Lyme disease is still a clinical diagnosis, and serology cannot be used to rule out early localized disease. There are minimal changes to the interpretation of the test results. And as Samir noted, the Lyme disease test information sheet has been updated and is available on the PHO website, with the main change just being that Western blot step has been replaced with another ELISA step. There are minimal changes to the IFAS case entry, and PHO has updated the Ontario investigation and tools for Lyme disease, and I'll just highlight that on one of the next slides. There is an updated version of the Ontario Health Clinical Guidance document. This was formerly a Health Quality Ontario document, management of tick bites and investigation of early localized Lyme disease. That was updated the last month, I believe. And the Ministry of Health Appendix 1 for Lyme disease has also been updated to reflect these testing changes. So these are some screenshots of the Ontario investigation tool. At the top is the old tool where it had the EIA, the ELISA results, followed by a Western blot. And now the newer version has the Tier 1 and Tier 2 ELISA results. And the new Ontario investigation tool is also a separate box for European Lyme disease testing, because that, as Samir noted, it is done differently with confirmatory testing at NML. This is a screenshot of the Ontario Health Clinical Guidance document, management of tick bites and investigation of early localized Lyme disease. So this is an updated version of the 2019 Health Quality Ontario document. On this page, it talks about management of a patient who is either asymptomatic or is symptomatic with symptoms of early localized Lyme disease. I'll go through some of this in the case studies. This is the second page about Ontario Health algorithm. And you'll note that the box 7, the sensitivity of serological testing has been updated to reflect the performance of the modified two-tier testing. And another change of note in this version of the document is that doxycycline is no longer contraindicated in children younger than 8 years of age. And there's weight-based dosing for children of any age provided. So to summarize what we've talked about so far, as of April 1st of this year, PHO has implemented the modified two-tier testing for detection of antibodies against Borrelia burgdorferi, replacing previous standard two-tier testing. And this newer algorithm has been endorsed by both the CDC as well as the Canadian Public Health Laboratory Network as an acceptable method. The sensitivity of the modified two-tier testing is about 15 to 25% higher than the standard two-tier testing in detecting antibodies during early localized disease. And PHO has updated IFIS and the Lyme Disease Ontario Investigation Tool to meet these new testing updates. And I have some links provided here that will be in the slides that are posted. That just gives links to some of those documents I talked about: the Ontario Investigation Tool, the test information sheet, the estimated risk area map, the Ontario Health Clinical Guidance document, and Ministry of Health Appendix 1 for Lyme disease. Now I'm going to go through 2 case studies to highlight some of these implications for testing. Well, the first case is a 68-year-old retired nurse living in Ottawa who was bitten by a tick while gardening. She took the tick to her local public health unit, but the tick was not sent to the lab at PHO for identification. A few days later, she developed a rash and flu-like symptoms. Upon examination, she was found to have an erythematous rash at the site of a tick bite that measures 8 centimeters. She was treated with doxycycline for 2 weeks, but her physician did not test her for Lyme disease antibodies. So questions for this case for you to consider are: what evidence supports the diagnosis of early localized Lyme disease? Should the physician have ordered serology? And if the patient returns and insists on getting tested for Lyme disease, how would you counsel her? Start by answering the first 2 questions using the Ontario Health algorithm. So for this patient, they are symptomatic following a tick bite. So we'll move down the right side of the algorithm in orange. Just zoom in a little bit. And because this patient does have a rash that is characteristic of erythema migrans, then this is sufficient for diagnosis of a clinical case of Lyme disease, and serological testing is not indicated. For the third question, the patient returns and insists on getting tested for Lyme disease, how would you counsel her? If you look at the second page of the Ontario Health algorithm, under box 6 for lab testing, it does highlight that the IgM antibodies will present typically within 2 to 4 weeks after infection, and IgG antibodies 4 to 6 weeks later. So if you are tested before this time, then it's quite likely that the test results would be negative. So testing too early in infection is not helpful in ruling out disease, and that's why for an individual with erythema migrans, Lyme disease is a clinical diagnosis, and this serological testing is not indicated. The second case is a 19-year-old student who lives in Kitchener. They presented to a doctor with the 1-week history of rash, described as a circular erythematous patch. They also had general flu-like symptoms, including fatigue, chills, fever, headache, muscle and joint pains, and swollen lymph nodes. They described no travel to risk areas for Lyme disease and no possible contact with ticks in the last month. What are your initial thoughts and workup? So again, looking at this Ontario Health algorithm, we have a patient who is symptomatic within 3 to 30 days. Here it says following a tick bite. For this individual, their symptoms have been persisting for less than 30 days, but they have no known tick bite. And it says, was the patient exposed to ticks in the past 30 days? They have no travel identified. And I'll look at the Ontario risk map, estimated risk areas, to see if Kitchener is within a risk area, and Kitchener is not within a risk area based on this risk map. So going back to the algorithm, we move down to the last step, and it says, was this patient exposed to a tick in the last 30 days? Yes, possibly, or no. So because they have no residence or travel to risk areas and no possible contact with ticks, then there is a lower risk of Lyme disease, but you should not rule out this diagnosis. You're advised to consider alternative diagnosis, and the differential diagnosis for an individual with rash is quite broad, a number of potential infectious causes. And if investigation for alternative causes does not identify another possible cause, then you could consider Lyme disease serology. So now I'll hand things back over to Catherine, who will be moderating the Q&A session of this talk.
Thank you very much, Richard. So there's a fair number of questions for you both in the chat. So the first question is just about reporting of results. And the question is, if one of the two ELISA tests is positive, will the clinician be made aware of the single positive test or only if both are positive?
Yeah, thank you. That's a great question. So similar to the standard two-tier testing, we used to report both ELISA testing, and if it was positive, we would report the Western blot testing. Even if it was negative, we would report the ELISA testing as well. So in this scenarios, that's what we would do as well. So if the first test is positive, we would go ahead and do the second test, and if whatever the result is, if it's positive or negative, both results will show up on the report along with the overall interpretation.
Thanks, Samir. Just a question regarding the testing at PHO lab. So if a physician were to request a standalone Western blot, is that still an option or has this been discontinued?
Yeah, so we've looked at the data before as well. So again, these tests, when there was a ELISA versus followed by Western blot, it was really looking at it in totality as well. So we our practice was not to perform testing directly on the Western blot. We always perform testing using Western blot if a sample was positive for ELISA. Having said that, there have been some instances where there was a complicated cases and we had done ELISA negative and directly to Western blot. And none of those instances we were able to identify any cases that were positive on the Western blots.
Thank you, Samir. So next is a question, if you can provide some additional information regarding testing for European Lyme and what areas in particular an individual would need to report in order for them to qualify for testing.
So there is more information on our test information sheet. Based on the national microbiology requirements, if a European Lyme disease or serology is requested, then the requisition should have where the patient traveled from, so at the country level, and the time of the travel. So, and it should be less than 12 months. So the current eligibility criteria is anyone traveled to Europe in past year, and clinician is suspecting European Lyme, then we would do the European ELISA and then send it off to National Microbiology Lab for confirmation.
Thank you. Next is a question, I think, about interpretation of our surveillance statistics on the analytics page. And just wondering if the reported cases are those that have had the two-tier positive test or what those reported cases include.
So the cases that I described previously, so that's probable and confirmed cases. So that would be using the existing testing method. So that's standardized two-tier testing. So anyone who meets that confirmed or probable case definition in the Appendix 1. And as you may recall, for individuals with early localized Lyme disease, they may not have a test result as that is a clinical diagnosis. So if a clinician diagnoses Lyme disease based on an erythema migrans rash, then they would be included in that case count, but wouldn't have a test result.
Thank you, Richard. So next, some questions regarding mapping. Are the Lyme disease risk area maps informed by tick submissions? And then are there any plans to create a more detailed map?
Thank you. So passive tick submissions in which ticks are submitted to your local health unit or sent to PHO for identification. Those are used to help inform where active surveillance is, but the estimated risk area map is based on active surveillance, so tick dragging. And the development of that is based on literature that we came out of New Brunswick or Nova Scotia, in which they assessed that was the best way to estimate a risk area. To say that a tick is established in a location, you want to be able to find it at least twice during the year, so both spring and fall. So if you were relying just on submission of a tick from one location, then that wouldn't be enough to sort of meet that criteria for an estimated risk area. Regarding a more detailed map, that is a great question. I believe our lead at PHO is looking into developing a more detailed map. There is a detailed version of the map that is available on the Canada.ca website. So we're thinking of developing something similar to that, where you can zoom in a little bit more, you can type in a postcode, and then that will sort of highlight on the map if you're within one of those estimated risk areas or not. So definitely something we are considering, but still under development at this point.
Great, thank you, Richard. Now a question about IgG and IgM. How many weeks following a tick bite after this do IgM and IgG typically appear?
Yeah, another good question. The study shows that IgM comes before and then IgG comes. So typically IgM starts developing after 2 weeks, 2 to 3 weeks following the symptom onset. And then the IgG would be looking at it from 3 to 4 weeks and onward. So that's how the IgM and IgG would develop.
Great, thank you. Now there's a question regarding Tier 1 indeterminate results and how these are approached in the lab. Is Tier 2 still reflexively performed?
That is correct. So as I mentioned, anything that's non-negative, so reactive or indeterminate, those samples would automatically be tested using the second tier or second ELISA method. And the results would be provided to clinicians.
Great, thank you. Next, we have 2 questions regarding treatment. So first, why is doxycycline no longer contraindicated in children?
So one of the main concerns with doxycycline was that it could result in teeth staining in children. But there was a study that looked at children who had been treated with doxycycline and as a control of children who had not been treated with doxycycline, and they had dentists who were blinded, and they examined the teeth of both children, and there was no significant difference in tooth staining or coloration between those 2 groups. So that was used as part of the evidence for why doxycycline is no longer contraindicated. I don't know if you have anything else to add there, Samir?
No, I think you got it right. Yeah, it was really the concern was teeth staining, and there have been studies, and the contraindication has been removed from the Red Book as well, which is published by American Pediatric Society.
Great, thank you. So I think a related question, does treatment with doxycycline affect future interpretation of results? I guess.
I can take that. So, I mean, we do know that if patients are treated early, some patient may have a delayed antibody response in terms of the development, or may not develop any antibodies as well. So it doesn't matter if it's a doxycycline or amoxicillin or other recommended antibiotics used to treat Lyme disease. So there is some evidence that it may impact antibody development, either delayed or may suppress the antibody development.
Can you comment on testing performed by private labs? Have private labs also adopted the same 2-tier approach?
So in Ontario, Public Health Ontario is the only laboratory that does testing for Lyme disease. So I can't really answer what the private labs are doing.
Great, thank you. And then there's just a question regarding tick submissions and how PHO handles submissions of ticks to health units or physicians. Does all of this data reported upward, or how does that information make its way?
Maybe I can start, and I don't know, Richard, if you want to add anything. So we still accept ticks from someone who's submitting through his or her physician or local public health unit. And this is what Richard was talking about in terms of the passive surveillance. PHO identifies the tick and then would report the results back to clinician, whether it's a black-legged tick or whatever the tick is. It's still very important to know that tick identification and other things is for surveillance purposes only and should not be used to make a clinical decisions or management of patient, because it is primarily used for surveillance purposes.
Okay, thank you. And then a more general question, is it possible to be reinfected with Lyme disease?
Yes, and this is one of the challenge with the serological testing, because we can't differentiate a patient who was infected last year and the chances and versus new reinfection as well. So once you're if you're infected and you have antibodies, you're not immune for life. And there is a risk of getting reinfected if you're exposed to infected ticks in subsequent years.
Thank you. Next is a question, if you could just clarify why serological testing in early localized Lyme might be contraindicated.
Well, the concern there could just be the interpretations of a negative result. So a negative result in serological testing in early localized Lyme disease, we wouldn't want a clinician to use that to rule out Lyme disease, because the sensitivity is low at that point. It really is a clinical diagnosis. So as the diagnosis should be based on that clinical assessment, in someone with erythema migrans rash, then there would be no benefit of adding that testing. Sphere, any other comments?
Yeah, no, absolutely. I think it's not generally contraindicated. It's just that you should not be using the results, particularly in the early localized disease, to make diagnosis, because negative results does not rule out Lyme disease in that instances.
Okay, thank you. And next is a question regarding one of the case studies that you presented, Richard. In the example you gave for case 1, if that patient had been tested 4 weeks after treatment, would antibodies still have been present?
So an individual who is treated for Lyme disease, then that treatment, it can affect seroconversion. Samir may be more familiar with some of the studies on that, but so it's possible that it would be positive, but even if they were infected and did have Lyme disease, receiving antibiotic treatment, it may impact the seroconversion, so the test results may not be positive.
Yeah, if I could just add, one of my earlier point as well, if you're making a clinical diagnosis, you really do not need to test the patient, because it's a clinical diagnosis. And while I said that it may impact if patient is treated earlier, if a patient is tested 4 weeks after the treatment, and if it's positive or negative, it would not have any impact, or one would not change any management of that patient.
Great, thank you. Can you please talk about the specific components that are actually being detected in the ELISA test in the 2 steps of the new testing algorithm?
Yes, so we're using the whole cell lysate. So whole cell lysate is pretty much, in a very layman's term, a bacteria is broken down, and the ELISA plates are coded against all of the bacterial component of Lyme disease. You put the serum sample or blood samples on it, and it'll bind to antibodies that would react with the bacterial component as well. So that's called whole cell lysate. The second tier is the PepC10, which is a variable VLSC PEP10 protein. It's a recombinant protein. It's much more cleaner in terms of the ELISA development. So those are the 2 different chemistries that we're using. So we're not using the same ELISA method twice. We're using 2 different chemistry to increase both sensitivity as well as the specificity as well.
Okay, great, thank you. Then another question regarding the potential for reinfection. How long is the typical immunity for Lyme following the first infection? Is there a short-term immunity?
Sorry, go on.
Go ahead.
Yeah, you can be reinfected with Lyme disease. I'm not aware of a time period in which you are immune after the first infection, but I was going to hand it over to Samir if he had any more insights.
Yeah, no, I mean, there have been studies that you could get, there is a short-term immunity. And the rule of thumb has been that in one particular season, if you're infected, you're treated, the chances of you getting reinfected in the same season is low. The next season, the chances are higher if you of getting reinfected. Following season, it's even higher if you were not infected. So as the time goes on, the chances of you getting reinfected and your immunity goes down are higher as well. But the studies have shown that if you were, for example, if you were infected and treated in 2023, and you have sufficient antibody response, you're more likely to have an immunity for this particular season and for getting reinfected.
Thank you. There's another question regarding the sensitivity of the MTTT following treatment, and would testing ever be considered after treatment?
So again, the testing is used to support clinical suspicion of Lyme disease and to make a diagnosis. And as I mentioned earlier, if you've already made a diagnosis of Lyme disease based on, and particularly in the early localized disease, you should not be ordering testing to either confirm your clinical diagnosis, particularly in the early localized stage, or monitor treatment. So in this case, if someone's already been diagnosed, treated, there is no role of ordering testing following the treatment.
Great, thank you. There's just a question regarding PHO's technical report, the update on Lyme disease prevention and control, and whether this will be updated to reflect these testing changes.
Yeah. Oh, sorry.
Yeah, no, that's a good question. I think we'll take it back in terms of the technical report was published back in 2011, so we will take it back just on that one.
There's another question related to immunity. Just wondering, how long after an infection do antibodies typically last? And is a person immune as long as antibodies are present?
So the short answer is no. The antibodies last for years, and I haven't seen any correlation as to presence of antibodies equal immunity. So I think that's the take-home message for that.
And finally, there was just a question wondering when the slides go out, will the link to the result interpretation for the new serology be somewhere within the slide deck? It was on a slide briefly in the presentation.
Yes, it will. I can post that in the chat now if that's helpful.
That would be great. Thank you. What is the recommended duration of antibiotics?
That would depend on the stage of infection. On the algorithm I posted from Ontario Health, that was for early localized Lyme disease. It is also if an individual is exposed to a tick, a physician can consider post-exposure prophylaxis, which is just a one-day course. Typically for early localized Lyme disease, I believe it's 14 to 21 days of doxycycline is typically recommended, but there are more detailed recommendations in that Ontario Health algorithm. And then for different stages of Lyme disease, there are different durations of treatment.
Great, thank you. I'm not seeing any further questions for either of you, so thank you. As we wrap up today's PHO rounds, I'd like to thank both Dr. Samir Patel and Dr. Richard Mather for presenting, and thank you to everyone who joined us for today's event. You can expect to receive a brief and anonymous PHO round survey for today's session. Please try to complete this to help us improve our future programming. And lastly, to access past PHO rounds presentations and to view any confirmed upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you and have a wonderful day.